Hello, I think we can start.
Hello. Hello, good evening, everyone. Welcome you to this today's lecture series. So we're going to take 3 topics today. We're going to start with the vaginal fistula. So next slide, please. Next slide. Hello, next slide, please. Okay. Now, the vaginal fistula in developing countries is mainly an obstetric fistula, and it is an unfortunate outcome of pregnancy and labor. On average, there are about 2 million women affected with vaginal fistula worldwide, and up to 90% of these women are in Africa. Annually, about 100 to 150,000 new fistula develop. However, the incidence or the occurrence of fistula is not really related to race, religion, culture, or tribe. It predominantly reflects the quality of obstetric care in a given country. The 2 main types of obstetric fistula are the vesicovaginal fistula and the rectovaginal fistula following obstructed labor. Next slide. So what is the etiology of vesicovaginal fistula? The main etiology of vesicovaginal fistula in Africa and the developing world, in particular in sub-Saharan Africa, the main etiology is obstructed labor. Other causes include cesarean section in the second stage of labor for somebody with obstructed labor, or obstetric practices. These obstetric practices also include traditional practices such as gishiri cord, or when labor and manipulations are conducted by TBAs at home. Next slide. So what are the structures at risk following an obstructed labor? Anterior to the placenta, to the uterus, is the vaginal wall, the bladder, and the urethra. This is particular in obstructed labor when the presenting part or the presentation has already entered into the pelvis. So the anterior vaginal wall, the bladder, and the urethra are at risk, while posteriorly, the posterior vaginal wall and the rectum are at risk. Similarly, the lateral vaginal wall could rarely be involved. Can also have the cervix or the lower part of the uterus. Of course, the deeper pelvic structures that are entrapped between the head and the other structures. In 85% of vesicovaginal fistula, women presented with isolated VVF alone, while in 10 to 15%, they present with both VVF and RVF. Very rarely do you have isolated rectovaginal fistula. And it mainly occurs because of a poorly repaired or unrepaired ruptured anal sphincter during labor. Next slide. So how are vesicovaginal fistula classified? The classification can be based on the size, based on the location, and based on ability to have continuity even after repair. So based on size, you can have a small fistula when the fistula measures less than 2 centimeters, a medium fistula when it measures between 2 to 3 centimeters, a large fistula when the fistula measures between 4 to 5 centimeters, or an extensive fistula where it measures 6 centimeters or more. Next slide. Based on the position, that's the anatomic location of the fistula, it can be juxta-urethral, where it is within 2 to 4 centimeters of the urethral opening, can be mid-vaginal, juxta-cervical within 4 centimeters of the cervix, or ureteric, when it is the ureter that is involved and has a connection with the vagina. In that case, mainly the injury occurs at the region of the trigone, and therefore the urethra that is just entering the bladder will just have a direct connection with the vagina. Next slide. So how do you make a diagnosis? The diagnosis of obstetric fistula is predominantly based on a history and examination findings. When you take a history, you start from the biodata, usually a young man, a primary gravida, who had a poorly supervised antenatal care and who had prolonged labor with or without manipulations during labor by the traditional part attendant. Okay, and then of course, usually the outcome of the labor you can find out from the history. The labor was prolonged. The fetus was delivered severely asphyxiated or even dead. She ended up with a cesarean section, or she ended up with assisted vaginal delivery. Now, if the fistula has been long-standing, there may be a history of an attempt at repair or even several attempts at repair of the fistula. Of course, there's usually copious history on the social and family aspect. Usually the woman is poorly or even not educated. She's not employed. She's married to a spouse who also has low education and low socioeconomic status. And usually some at the point of you're meeting them, they've already been divorced by the husband. And at that point, she has no significant family support. Of course, there will be history of nutritional deficiency. She's abandoned. She's actually begging for food. And she's usually obviously malnourished. Next slide. Now, next slide, we'll talk about this one. Next. When you examine her, of course, assessment of the height and weight, and therefore the body mass index is important. Most fistulae that occur in primiparous women in their first pregnancy are usually found in the young teenage pregnant woman who actually was married at an early age, who had not attended her full pelvic growth potential at the point of marriage, pregnancy, and delivery. So you might find that she has a short height, a height less than the obstetric height, which is 1.52 meters. She may be underweight, and of course, therefore, she may be underweight when you estimate the BMI. She may be anemic, and you may have other comorbidities. Reason is that she may have, because of prolonged compression of the sciatic nerve in the course of the labor, she may have foot drop. She may have ammoniacal smell. There may be ammoniacal dermatitis. She may be having UTI. So many problems may be associated with the patient. And of course, when you have to now examine, after making diagnosis, you need to know the number of fistulae, the type of fistulae, and the size, so that you plan for the delivery, for the repair. Next slide. So now, in some situations, it may not be very clear. It may be difficult for you to fully assess the fistula. You may need to do examination under anesthesia with or without a dye test to identify the site, the size, and fully characterize the fistula. In this case, the patient is taken to the theater. She's usually given local anesthetic or spinal anesthesia or saddle block. She's positioned, you can use either lithotomy or use left lateral position, and then use the appropriate equipment, instrument, and then you examine the fistula. Sometimes when you have a fistula that is associated with some continents, you may need to do a dye test so that you'll be able to fully identify where the urine is coming from. For you to be able to do that, you definitely need a good light source and a good operator bed to actually position the patient. Of course, you need a lot of retractors. But the simplest retractor that you use in examining a fistula patient is the Sims speculum, which is used in left lateral position. That's the Sims position. Next slide. So what are the investigations you need to do for a patient fistula? Because you need to do a full blood count to assess level of hemoglobin. As we said, some of them will be anemic at presentation. So to assess the hemoglobin level, so that if there's anemia, you need to optimize. You may also find elevated white blood cell count if there's an ongoing urinary tract infection. So, and then of course you need to do urinalysis, which will be a window into a potential UTI. If you use Combinine, you may have detect proteins, nitrites, white blood cells, which may suggest the need for you to do urine culture. You may also need to consider doing urine culture in the setting of a malnourished woman who came from the rural areas. Sometimes you need to do intravenous urography to assess the function of the kidney. But you must remember, before you do intravenous urography, you must do urea electrolyte and creatinine, because you don't do any contrast study of the urinary tract, especially upper urinary tract, if the patient has impaired renal function. Next slide. So when do you operate? When do you repair the fistula? The repair can be done early or delayed. Those who advocate early closure do take this view because it is, for them, it is viewed that at the point you are assessing the woman, if there's no obvious infection or inflammation, and you think that the tissue is good enough, then fixing the problem at that repair, doing the repair at that time, will give her a better outcome. If the fistula heals, she'll be better off psychologically. You've lessened the burden of her worry and stress while waiting. While on the other hand, those that advocate delayed closure have the opinion, which is also true, that when there's an obstructed label and a fistula result, there will be a lot of dead tissue around, scar tissue around, until the inflammation and has subsided significantly and there's no any urinary tract infection. You don't rush to repair. So there's those, of course, another thing you have to factor in as a surgeon, you also have to look at your own peculiarities. If the fistula is small, repairing early has a better chance because there's no inflammation, no infection, and the fistula is small, it's so good. So there are a lot of factors to consider when you're individualizing, but definitely the repair is either done early or close or delayed. In the past, they only advocate for delayed closure, but now you can decide to repair it early or you can decide to delay it until inflammation has subsided. Next slide. So what is the treatment for a patient with VVF? Now, apart from this physical complication that has resulted from following obstructed label, there are other complications that can accompany obstructed label. So it means it's not only sufficient for you to repair, you need to also rehabilitate the patient. And this rehabilitation may be physical rehabilitation or even occupational. As we said earlier, some women at the point you are seeing them have been divorced, has no source of livelihood, and therefore they are actually trying to survive. So in those patients, apart from doing the repair, you need to also, where possible, provide occupational rehabilitation. We said there are other complications like foot drop. So she will need physiotherapy. She may need a foot support that will help her move better. So all these are part of rehabilitation. Repair is the first goal. Of course, you have to rehabilitate. And of course, you must talk about prevention because it is a preventable morbidity amongst women. Next slide. So, but it's not just the repair. The thing about vesicovaginal fistula is that the post-operative care is as good as the repair itself. You may do a repair, but if your post-op care is bad, all your efforts will be wasted. Now, post-op, it's important to know that after a repair, the goals of management post-op is that you want to ensure adequate drainage of the bladder. And to ensure adequate drainage, you need adequate hydration such that the patient will be making about 50 mils of urine per hour. 50 mils of urine per hour, so that in 4 hours. Then the next goal, of course, I say you must ensure continuous catheter drainage of the bladder, which means the catheter is passed and it is ensured that the catheter is patent and not blocked every time. And it's important that whenever the catheter is not draining well, it must be assessed and the reason sorted out immediately. Of course, you should provide analgesia and then provide antibiotic cover. Antibiotic prophylaxis is given, but what others, depending on the circumstance. But then if there's any evidence of infection pre-op, you have to place on antibiotics to prevent a recurrence because an infection will lead to breakdown of the repair. Next slide. So how do you prevent BVF? Prevention can be primary, secondary, and tertiary. Primary prevention has two components: passive and active. Passive protection is what involves health education. So you have to provide health education on immunization because immunization prevents childhood preventable diseases that may have a long-term effect on adolescent growth for the girl child. This includes diseases like measles and poliomyelitis. If a girl child develops poliomyelitis, she will have an abnormal gait and she will have defective pelvic growth, and therefore that defective pelvic growth will lead to a constricted or contracted pelvis and a potential cause of obstructed labor. If your child has measles because of lack of immunization, she can develop malnutrition. Malnutrition can eventually lead to growth stunting. And in the setting of early marriage with poor girl child education, she will get pregnant when she has not attained full pelvic growth, and therefore she's at risk of development of obstructed labor. And of course, health education on infant and child nutrition, so that at the age of puberty, when that great growth spurt is starting, there should be adequate nutrition to allow for appropriate pelvic growth. Because if there's malnutrition at that age, the pelvic growth will not be attained. And if there's also associated early marriage, then she'll get pregnant before she attains full pelvic maturity. And that's a risk factor for obstructed labor. Of course, girl child education. Educate the community and society about girl child education. Because an educated girl is a better contributor to the development of the society. Because an educated mother, educating one female child is more than educating 10 men. Because an educated mother is more likely to ensure that all her children are educated. Then, of course, an educated child is likely going to be an empowered woman. An empowered woman has a better chance of seeking healthcare at the appropriate level at the right time. So these delays that lead to maternal morbidity and mortality will be reduced. Then, of course, family economic empowerment. Poverty is a disease because it is associated with all forms of complications. All bad decision making about healthcare are related to poverty. Then, of course, community education and mobilization. If the community is well informed, they will be well mobilized to seek healthcare at the right place at the right time. This is primary prevention. Now, under primary prevention, we said passive. Passive protection is the education on nutrition, girl child education, and family empowerment and community mobilization. The specific protection is the immunization against childhood diseases so that it will prevent malnutrition and poor pelvic growth. Next slide. Next slide. Now, secondary prevention. In secondary prevention, the goal is provide prompt diagnosis, early diagnosis, and treatment. So it's only possible to diagnose obstructed labor early or a difficult labor early when you have what you call emergency obstetric care or emergency obstetric and neonatal care services. But then all these services will only be possible if there are accompanying social and community development or infrastructure available. Good roads, good communication networks, and good ambulance services. These three will help you ensure that with when you have basic emergency obstetric care, there's a problem at the primary care level, it will be easier to refer the patient to the secondary care level where she can receive comprehensive emergency obstetric care. What does it mean by comprehensive emergency obstetric care? All our secondary health services should be able to monitor labor, detect prolonged labor, manage prolonged labor, and offer cesarean section and blood transfusion. If our secondary or general hospitals can do this, then we'll be able to prevent obstructed labor and its consequences such as VVF. Now, where does community participation come in? Now, remember when we talk about maternal mortality, we have the 3 delay models: the first, second, and third. First delay, inability of the people at the family and community level to identify that there's a problem and take a decision to go to your hospital. Second delay, difficulty reaching the health facility. Third delay, they got there, but the person cannot do the right thing. Poor decision making at the facility level is the third delay. So it means if the community is mobilized and willing and educated enough, they will be able to take care of first delay. And if there are good roads, they will take care of second delay. And then, of course, if there are emergency obstetric care services in the hospital, the third delay will be handled. So overall, for you to successfully detect and prevent obstructed labor, you must have trained healthcare workers at the facility who will be able to use a pathograph to detect the progress of labor, identify abnormal labor, and institute corrective measures or refer the patient to the appropriate level where intervention can take place. Without this, we'll not be able to prevent VVF. Next slide. Tertiary prevention is about rehabilitation. It has happened, so what do you do? Now, for VVF, tertiary prevention is a matter of training and retraining of obstetric gynecologists and surgeons, whether they're general practitioners or specialist practitioners, on providing fistula repair. So training and development of standards of care are important for handling fistula patients. In addition, development of a robust rehabilitation mechanism for patients that have developed fistula. This includes physical rehabilitation, physiotherapy, providing of orthostasis, and as well as provision of occupational therapy or occupational rehabilitation for those who have lost means of livelihood. Next slide. This is the end. So if you have any question, you jot them down. When we take the next topic, we'll take your questions. Next presentation, please. I'll get back with you. We're going to look at the pathograph. The pathograph, at the end of this discussion, we should look at the aim is that the objective to understand the principles behind the use of the pathograph, how to plot the pathograph, how to interpret a pathograph, and how to use a pathograph to manage the first stage of labor. So next slide. The pathograph is a graphic representation of all events in the first stage of labor. So the aim of the pathograph is for you to just glance at it and have an idea of the progress of labor so far from the time it was opened to the time you are taking over. It's an important tool for the management of labor as it helps to prevent obstructed prolonged labor, because prolonged labor is often a prelude to an obstructed labor. Next slide. This is a WHO pathograph. This is the old one. Up to now, agreement has not been reached about the new labor guide. If you look at this graph, it has, on the upper part, you have the patient's identity, the file number, the date she came, the gestation, the LMP, the EDD, and the EGA. It's at the top. Then below that, you have the fetal heart rate graph, where you plot the fetal heart rate. And this fetal heart rate is supposed to be plotted every 30 minutes. Based on these graphs, every 30 minutes. Then below the fetal heart rate, you have a place for the color of liquor and whether there's molding or not. Then beyond that, you have your cervical graph, which is the graph where you plot the cervical dilatation against time, against the time of examination. And of course, on the same graph, you also plot your descent. You also, because that is the part you assess the progress of labor as far as cervical dilatation and descent of the presenting part is concerned. You should, when you glance at that place, you should be able to know that this labor is progressing or not. Because that part is a hallmark of assessing labor progress. Then below that, you have a column for time. That's for time. Then you have your contraction chart, where you describe the contraction, the number of contractions occurring in 10 minutes, and then the duration of each contraction. Below that is your space for oxytocin therapy if you are using any doing any augmentation. Then of course beyond that is your treatment, whatever you are giving the patient, how much fluid, whatever you are giving. Then up beyond that is the maternal vital signs, the pulse rate, the blood pressure, the temperature. Then you have the volume of urine. Then of course it's expected that at least on admission we check your urine for protein and glucose and acetone. So there's a place for analysis dipstick. And so this is your pathograph. If you fill this pathograph very well, anybody you are handing over who is coming to see the patient, you wouldn't need to talk much. If he understands, he just lift it, look at it, and you will know what's happening. Now, I must tell you, this instrument was not developed for doctors. Yes, it's an instrument for managing labor that is meant for people at the lower level of healthcare. The CHUs, the midwives, and the doctors in the peripheral facilities. Because the essence is you should be able to communicate the state of labor, identify the situation, and if there's a need for referral, quickly refer the patient. Or if there's a need for intervention, institute the appropriate intervention so that you prevent the occurrence of prolonged labor and then the adverse outcomes that are usually associated with prolonged labor. Next slide. So the WHO estimates that every year about 210 million people get pregnant. And 20 million of this will experience pregnancy-related problems, while 500,000 women would die from complications of pregnancy and labor. Now, about over 90% of these deaths occur in developing countries, and most of these deaths are preventable as long as labor is managed appropriately. Next slide. Now, in 1987, actually, this concern was actually portrayed before 1987 when the Safe Model Initiative was developed, was launched. There was a Zaria maternity survey that took place between 1983, 1984, 1985. The massive data that was generated by Professor Kelsey Harrison and published as in a supplement of the British Medical Journal. The whole supplement was dedicated to publication. It was what pointed out clearly what happens in the developing countries regarding pregnancy, labor, and delivery. And following that, advocacy started and led to the 1987 declaration of the Safe Mother Initiative with the aim of reducing maternal mortality by 50% by the year 2000. Of course, most of these programs don't end up succeeding anyway. Now, after when the target was reduced by 50% by 2000, but it was not achievable. So by the beginning of the new millennium, the Millennium Development Goals were enacted in the year 2000 with the aim of reducing maternal mortality rate by 75% in 15 years. Well, it was also not achieved because if it was really achieved, obstetric labor should have been handled efficiently, but till date it's still a problem. Next slide. Now, it is said that prolonged labor in developing countries usually is a result of two problems. One, ineffective uterine contractions and obstructed labor. Now, if they, when you talk about labor, it's a relationship of three factors. They are called the three P's: the power, the passenger, and the passage. The power is the uterine contractions. The passenger is the fetus. The passage is the pelvis. So if the relationship within these three is not smooth, you have a problem with your labor. Now, if the powers that is uterine contractions, are not sufficient or effective in pushing the passenger down into the passage, then there's a problem. So inefficient uterine contraction or ineffective uterine contraction is one key contributor to prolonged labor. And the way to deal with it is what? Is you can only detect it when you are monitoring the patient during labor. And that is where the pathograph comes in. Obstructed labor is said to occur when, despite adequate contractions, no progress is ever possible without intervention, which means in this case, the uterus is contracting well, but the passenger is not passing down the passage. The passenger is not passing, it's not moving down, it's not descending, which means you have to intervene for it to deliver that baby. This is what's called obstructed labor. Now, in the case of obstruction, CPD is the commonest cause. Now, why do you say CPD? It's because the commonest presentation is cephalic presentation. And therefore, the commonest cause of obstructed labor is cephalopelvic disproportion. When the size of the passenger's head and the size of the passage are not, there's a misfit. One is smaller than the other, one is bigger than the other. So that's when you have cephalopelvic disproportion. In that case, the problem is not that of the powers. It's not a problem of uterine contraction. The problem is between the passenger and the passage. It's the commonest cause of obstruction, and it is often undiagnosed and untreated. And if that is what happens, it will lead to the following. When you have cephalopelvic disproportion that is not diagnosed, then it will lead to maternal dehydration and exhaustion, uterine rupture. Sorry, you have obstructed labor that is not treated. You have maternal exhaustion, there will be uterine rupture, VVF, fetal distress or fetal death. There can be maternal and neonatal sepsis and postpartum hemorrhage. So the consequences of obstructed labor are many. Remember, we just finished discussing VVF. Next slide. The common cause of maternal mortality in our environment, the main cause of direct maternal mortality environment include 1, postpartum hemorrhage, primary postpartum hemorrhage, sepsis, obstructed labor, rupture uterus. So you can see obstructed labor is the third commonest cause of maternal mortality in our environment, and it is mainly due to cephalopelvic disproportion and inefficient uterine contraction. So cephalopelvic disproportion and inefficient uterine contraction can both be diagnosed using the pathograph. In addition, obstructed labor and rupture uterus may contribute to 4 to 70% of all maternal deaths. In many countries, the maternal mortality due to this is almost as prevalent as it today as it was 30 years ago. But even in our environment, even though the rate of hospital delivery has slightly increased, we still get obstructed labor every day in Murtala, in Nasarawa, in Aminu. Most of these are referrals or patients who came from the lower facilities. Why? Because most health workers do not even know how to use the pathograph now. And even in most primary healthcare centers, and including the secondary healthcare, they don't even have pathograph available at present. Next slide. Currently, the appropriate management of active first stage of labor is the active management of labor. Well, this one was discussed or introduced by Audis Call in 1969. That's an old thing. The whole labor itself should be managed actively to prevent obstruction. We'll talk about this some other time. Next slide. So what is the active management of labor? We said labor has 3 stages. First stage, second stage, and third stage. And the first stage is it's up to 10 centimeters cervical dilatation. But for clinical purposes, we only admit patients whose cervical dilatation is up to 4 centimeters into labor. So from 4 to 10 centimeters cervical dilatation is first stage. From 10 centimeters to delivery of the fetus is second stage. And from delivery of the fetus to delivery of the placenta is the third stage. So, of the 3 stages of labor, the first stage has been the longest duration, has the longest duration compared to the second and third stage. And in clinical practice, the first stage of labor is the more tedious and challenging to monitor and assess. Yes, because the second stage and third stage, they are brief, so they are not as challenging as the first stage, all right? Therefore, the first stage of labor is the most important determinant of the entire labor process. It also has a longer duration and therefore deserves close assessment and monitoring in order to ensure a normal outcome. It is thus rewarding to look more at the details of the first stage of labor. Yes, because the duration can last up to 12 hours. I say if the labor, that stage can last up to 12 hours, it means anything can happen within those 12 hours, and therefore there's a need to monitor closely. Next slide. In active management of labor, it's a strategy. Okay, the strategy of approach of management of labor or managing active parts of labor aim at the prevention of prolonged labor based on it, because a labor, you assume that at least a woman's cervix should dilate by 1 centimeter every hour. And therefore, it means if it's dilating at least by 1 centimeter an hour, it means between 4 cm and 10 cm, it should happen within 6 hours. And second stage maximum of 2 hours, that should be 8 hours. So no matter what, a labor should not last 12 hours total, all right? So next slide. It is composed of a number of procedures in a structured protocol that ensures efficient supervision of the activities of labor for a duration of no more than 12 hours. The protocol is based on a set of principles as the foundation of a new body of knowledge, which the sharp departure from the prevailing knowledge at the time. That was what happened anyway. When we go to Audrey's call, in fact, the truth is that their protocol is not practicable in our environment. Next slide. Now, this is the protocol for active management of labor in a primary gravida as developed by Audrey's Call and colleagues in Dublin in 1969. There are 4 steps. 1, you do artificial rupture of membrane as soon as the woman is confirmed to be in active phase of labor. That's step 1. Step 2, you do vaginal examination every hour for the first 3 hours. So, of course, you confirm that she's 4 cm or more, you do ARM, because that's when you admit the patient. Then you do VE every 1 hour for the first 3 hours. If a doubt she's progressing at 1 centimeter per hour within the first 3 hours, then you now make the VE every 2 hours. So which means she came at, let's say she came at 4 cm, you did ARM, then you started examining her every hour for the next 3 hours, and she's progressing from 4 cm. By the next you finish the hourly examination, she'll be 7. So by the time she's 7, you should now change your examination to every 2 hours till she delivers. Now, when at the hourly VE or 2 hourly VE, the cervical dilatation has not increased by 1 centimeter per hour, you commence oxytocin augmentation, which means at the time you are doing the VE every hour, you expect that to increase by 1 hour. So if that is not possible within those 3 hours, then you commence oxytocin infusion, excuse me. Or on the other hand, when you examine her every hour, she was progressing at 1 centimeter dilatation per hour. But then by the time she was 7, she stopped progressing at 2 centimeters every 2 hours, which means by the third examination, she was 7. By the next examination, she was, instead of being at 9, she was still 8. So commence oxytocin augmentation. And then continue doing VE at 1 hour rate to ensure that the cervix is dilating at 1 centimeter per hour. Now, if you look at this protocol, it's too intense. It means you need to get at least have at least 1 midwife per patient. because on one patient alone, she will end up doing like 6 to 5, at a minimum of 5 to 7 vaginal examinations. You must have enough manpower for you to do that. Next slide. Now, oxytocin augmentation is run for a maximum of 4 hours duration. And if there's no delivery after augmenting for 4 hours, you do cesarean section for CPD. And therefore, one nurse is assigned to every parturient as companion, and they are given commitment to deliver within 12 hours of admission in active phase of labor. Now, but the good thing about it is that CPD is only diagnosed in primary gravida after oxytocin augmentation to eliminate uterine inertia, which is more common now. Why this statement is important is that in most primary gravida, they tend to have ineffective uterine contractions, and therefore it's important that in primary gravida, the moment the cervix is not dilating at 1 centimeter per hour, you commence oxytocin. When you commence it, you rule out inefficient uterine contraction, and therefore whatever it's causing failure to deliver is ECPD. So that's why, but this protocol is that it is associated with a high vaginal delivery rate, but it is resource intensive. You need a lot of manpower to be able to effect this. Next slide. Next slide, please. Next slide. Now, what was the result of the protocol? The active management of labor yield revealed excellent outcome. The prolonged labor rate was less than 1%, and cesarean section rate was about 5%. Similarly, instrumental delivery was less than 5%, especially for low force, and only low force were involved. And babies were delivered with good Apgar score, with a high morale and satisfaction from the mothers. But this protocol is difficult to implement in an environment because of social factors, economic factors, as well as human resource factors. Next slide. What are the problems of active management of labor as proposed by Audrey's Call? One, high cost in terms of material and manpower, high oxytocin augmentation rate of over 35%, 55%, and this protocol is only applicable in tertiary care centers with a large complement of staff and with good obstetric knowledge. And of course, because of this, the results could not be reproduced in several units in different parts of the world. And that is what led to the loss of interest in the active management of labor as proposed by Eduscol in the 60s. Next slide. So, hello? Hello? Next slide. What happened to the slides? Taisha. Hello? What happened to the slides, please? Hello there. Okay. I think we're going to the next one. Okay, next slide. No, let's go to the previous slide. Okay, next slide. Okay. Now, the advantage, what is the advantage of using the pantograph? The pantograph enables early detection of abnormal labor and prevention of prolonged labor, which will reduce the fatal and non-fatal complication of obstruction. The pantograph is therefore designed to show the progress of labor at a glance and therefore indicate when augmentation or termination of labor is indicated. It may also help reveal or detect disproportion long before labor becomes obstructed. Yes, that's a good thing about the pantograph. What is important is what? The ability to recognize the problem as depicted in the pantograph. But remember, all these things are only possible if the pantograph is filled appropriately. If the person managing the labor did not fill the pantograph appropriately, it could lead to wrong judgment by the interpreting physician. Next slide. So now, what's the history of the pantograph? The pantograph was first developed after the initial depiction of how labor itself, the graphic depiction of labor itself by Friedman in the 1950s. He first described the normal graph of the cervical dilatation pattern, which is sigmoid in nature. And based on this, the labor was functionally divided into two parts: the early or latent phase and the active phase. And the active phase is said to have a phase of rapid dilatation, a deceleration phase. Next slide. Now, this is the Friedman curve. It shows you that in the latent phase, the cervical dilatation is very slow. Then you have the acceleration phase when there's rapid cervical dilatation. And then, of course, you have the deceleration phase. This is the first curve on labor that was developed by Friedman in 1954. Next slide. Where the pantograph we're using itself was developed by Philford. Now, in 1969, Hendricks did not find the deceleration phase and noted that similar curves were found between primiparous women, primigravida, and multiparous women. In 1974, Christian added the descent of the presenting part in fifths notation. That descent is Crichton's fifths. 5/5, 4/5, 3/5, 2/5, 1/5, 0/5, which could prove dangerous in the hands of the inexperienced. John Studd used a stencil to show the cervical dilatation from 0. Next slide. Now, the composite pantograph that we're using today was developed by Philford and Castile as a tool for managing the forces of labor in the context of active management of labor. And this was developed in Africa here. It was developed by Philford in Zimbabwe. At the time, the biggest of the obstetric problem was prolonged labor, for which active management of labor, as enumerated by this call, was considered the standard management to prevent prolonged labor. However, several units, as we said earlier, were unable to implement the protocol as proposed by this call because of the high cost in material and manpower. So next slide. Philford and Castile, like others, had serious manpower constraints to develop or to implement the active management of labor as enunciated by Audrey's call. But because he had midwives at the peripheral units who conducted the bulk of the deliveries and only few staff at the referral center in Harare, had the skill to implement the active management of labor. However, he was anxious to reduce prolonged labor. Next slide. Hence, Philford had to modify the active management of labor protocol to suit the local constraints and rely on the core principles of anticipating normal progress at the rate of 1 centimeter per hour until delivery. He designed the composite pantograph as a tool to implement his version of active management of labor, which involved the midwife at the periphery who conducted the bulk of the deliveries. Next slide. He incorporated the idea of alert line, which was the visual line of labor progress at the cervical dilatation rate of 1 centimeter per hour throughout the active phase of labor for the ease of understanding by the midwives. Right? For labor progress of 1 centimeter per hour or more, these were normal, and labor supervision by the midwife is okay at the peripheral level. The cervical dilatation graph remained to the left of the alert line on the pantograph. Everything is okay. Now, next slide. I will explain later. For those with cervical dilatation less than 1 centimeter per hour, the plotted graph will cross the alert line, which visually shows cervical dilatation less than 1 centimeter per hour, which is a labor anomaly known as slow progress. Such women were referred to the referral center in Harare, which was about 4 hours away from the peripheral unit. Now, how he came about actual line and alert line was that since Odisco proposed that the minimum rate of cervical dilatation for active management of labor should be 1 centimeter per hour. So he now plotted that alert line to represent the minimum rate of cervical dilatation of 1 centimeter per hour. So as long as the labor is progressing normally, all the cervical dilatation you're plotting against time will be along the alert line. In fact, if the labor is progressing faster, the plot will be to the left of the alert line even. In that case, there's no problem. Such labor can be managed by the midwife. On the other hand, if the labor is progressing at less than 1 centimeter per hour, it means the plot will be to the right of the alert line, which means this labor is not normal. Therefore, such patients can be referred to the next level of care. And why he chose a gap of 4 hours between alert line and action line, it was not based on any science. It is based on his own peculiarities. The peripheral hospitals were located about 4 hours from the capital of Zimbabwe, which is Harare. And his own referral hospital was in Harare. So it means from the time they noticed that the labor was not progressing at 1 centimeter per hour, they have 4 hours for the patient to arrive from the local area to Harare. So within those 4 hours, the outcome is still okay. Within 4 hours from the time the labor is deviating, up to the time they come to the referral hospital, it can take them up to 4 hours, but the baby and the mother will still be okay. That's the essence of plotting that action line. Next slide. There was also the action line drawn parallel to and to the right side of the alert line at 4 hours. This represents the point when the cervical dilatation of less than 4 or 1 centimeter per hour has been delayed for 4 hours without progress. On arrival at the referral unit, those not yet delivered will have prolonged progress touching or crossing the action line to signify that labor progress, delay progress of labor, which is 4 hours, which is the 4 hours of journey from the peripheral unit. So that is the explanation. The gap between alert line and action line was based on the convenience of Philford. And it is okay, even in an environment, even if a patient is from Dogon Gynae, she can get to Kano, if there's a transport, she can get to Murtala before 4 hours. So it was said, okay. Next slide. At the central unit, now it is the patient is now assessed for the reasons or the cause of the delay. If the membranes are still intact, artificial rupture membrane is done, and after excluding CPD, oxytocin augmentation is commenced to treat uterine inertia. This strategy of alert and action lines help to select women with labor anomaly, which is slow progress at the peripheral unit for the referral to the central unit, where there are personnel with obstetric skill to manage the causes or the cases further to forestall complication. So that is the logic behind the alert line and the action line. Next slide. The 4 hours location for the action line to the alert line is a journey time I've explained. So the 4 hours was not derived statistically or scientifically, but only as an estimate of the duration for the transfer of the patient from the peripheral unit. And sadly, since that time, nobody has decided to change this matter. Next slide. Since the knowledge and skill to solve this problem do not exist, I understand. Same thing. Next slide, please. Now, hitherto, several cases of prolonged labor at the extremes used to be referred from the peripheral unit to the central unit because the staff at this unit lacked the means to identify those who could develop prolonged labor early enough to institute preventive measures. Now, if you look at this thing from our environment, if you could appropriately train and deploy pathograph in the rural areas, most of the case of prolonged labor or unaffected labor we have will be prevented. But then, providing the pathograph and training at the peripheral level is not sufficient enough. Patients need to have a means of transportation that is effective and efficient for them to reach the hospital. There's also a need for effective communication between the referral hospital at the periphery and the referral hospital within the more urban or suburban areas, maybe if it's general hospital or even the teaching hospital or special hospital within the city. So these are issues that need to be sorted out for us even benefit from the use of the pathograph, even if we deploy it at every hospital level. Next slide. The core of active management of labor principle of preventing prolonged labor through the anticipation of normal progress of labor at 1 centimeter per hour as initiated by Audrey's call, but represented by the more ideal novel idea of alert line on the field force photograph, allowed this anticipatory strategy to visually recognize and understood by midwives and other medical officers with low obstetric skills and knowledge. The essence is, if you have a graph and you can easily look at the graph and know what's happening, provided the information entered is correct, then you will know that this labor requires referral or the patient can stay within the same facility. Next slide. Transfer women whose labor progress cross the alert line and hence have developed slow labor progress for obstetric care at the central unit is the most appropriate way to prevent slow labor progress from developing further to full-blown prolonged labor and its sequelae. This is the main principle of active management of labor as enunciated by Audrey's call, which Filford has used the pathograph at that line system to achieve. So Filford used the information and the guide from Audrey's call to develop a more practical solution to manage labor. Next slide. An actual line at the central unit 4 hours later. At the central unit 4 hours later, allow action like oxytocin augmentation to be performed. And while those with good progress had vaginal delivery, those who had poor or no progress response ended up with a cesarean delivery. Monitoring with VE was performed every 4 hours and not every hour as proposed by Audrey's call. Next slide. The outcome of the pathograph to implement active management of labor was good with low prolonged labor rate, low cesarean section delivery rate, and babies had good ABGAS scores at birth. These results were comparable to the Audrey's call result, even though the protocol was substantially modified to involve the midwife to initially manage the labor at the peripheral unit to deliver those with normal progress but transfer those with slow progress. Next slide. The WHO adopted the Filford pathograph and modified it as the WHO pathograph and recommended it and the protocol as the preferred version of active management of labor for use in all settings of healthcare because it was cheaper to implement than the Audrey's call version in terms of manpower and material resources required. Next slide. The Pilford Pathograph involved the midwives and doctors in referral linkage to ensure comprehensive care of active phase of labor that can be used in all levels of healthcare. Whereas the Odiscol version of active management of labor could only be used in a tertiary health center with a large complement of skilled obstetric staff who had to be involved from early active phase in the labor management. So you see, the use of the Filford pathography is the best and has been the one adopted. But the fact that it is derived or it is modified from the active management protocol as proposed in 1969 by Driscoll, it tells you that yes, for every innovation in healthcare, you need to adapt it to your local peculiarities. And Filford, that's what he did in Zimbabwe. He modified the protocol as proposed by O'Driscoll to suit his peculiar situation. And sadly, this is what we have been using for decades. Next slide. The WHO pathograph was adopted from the Filford pathograph. It retained the alert line and still maintained fast separation of the actual line from the alert line, even though the fast location of the actual line from the alert line was not derived statistically or from any clinical study. Next slide. The WHO retained the 4-hour separation because the result of the actions delay for 4 hours were still acceptable in current practice. And most so, the 4-hour action line involved the midwives and others in the peripheral unit in the joint conduct of active management of labor to prevent prolonged labor. Maintaining the 4-hour action line made the pathograph a tool that could be used in any health setting for active management of labor, prevent obstructed prolonged labor. So the 4 hours was good enough. It could allow for all the delays possible, delays in getting transport, delays in mobilizing resources, since there's no access to a centralized health insurance system. So therefore, people in the villages, in the peripherals, have to mobilize resources to come to the cities. And if the referral is done early, the 4 hours is still good enough for the patient to prepare to come. Next slide. The WHO pathograph has gone through several versions, but the current version, which is a simplified WHO, is easy to use and requires the recording from active phase of labor, which is now 4 centimeters cervical dilatation in all women, and V is repeated every 4 hours or earlier if indicated. The protocol for the use of the WHO pathograph is the same as for the Filford pathograph. Next slide. When labor progress crosses the alert line, it is a signal that progress is less than 1 centimeter per hour, which is indicative of slow labor progress. At the peripheral unit where a parturient should be transferred for obstetric care in the nearest referral center, but in a tertiary center, such a parturient should be handed over to the obstetric staff to assess the cause and subsequently manage the slow labor progress and prevent it from becoming a full-blown prolonged labor. Now, this second part of the paragraph, this bullet point, is clearly showing something, that even within the referral or the central specialist hospitals, so let's say specialist hospitals or general hospitals, there should be clearly 2 units managing labor. It should be the midwife unit and the doctor's-led unit, whereby if a woman is in labor and they're using the pathograph correctly, and she's progressing at 1 centimeter per hour or less, she should be managed entirely by the midwife. But if the woman has labor that is not progressing at least 1 centimeter per hour, based on the pathograph recording, she should be reviewed by the doctors and appropriate measures instituted. The reason for this is that whenever you involve doctors in the management of labor, all of it, then you are over-medicalizing the process of labor itself. Because most women, out of 100 women, 80% of women will not require any intervention by any doctor. And that is the mistake we keep making at our own tertiary institutions, the teaching hospitals and specialty hospitals. Doctors are unnecessarily taking over labor management for no reason. It should be clear, there should be a clear protocol as to what type of patient will need the doctor's review and what type of patient will not need the doctor's review. Next slide, please. For the woman whose progress is at the rate of 1 centimeter per hour or more, the pathograph will remain to the left of the adult line and hence normal progress. Such women with normal progress will have labor managed by the midwives to delivery, either at the peripheral or central unit without the need for any obstetric involvement. Next slide. What are the advantages of the WHO pathograph? It provides a comprehensive view of all major features of the first stage of labor with their relation to the passage of time. Any abnormal feature of mismanagement of labor is immediately evident on examination of the pathograph. The handover all rounds by doctors, midwives, and nurses is simplified. The graph provides a good vehicle for teaching of medical students and student midwives. It is time-saving and more efficient than other methods of recording labor features. It is simple and skill in its use can be acquired quickly. Next slide. Next slide. Okay. What are the contraindications of the use of the pathograph? The pathograph should not be used for the following conditions. 1, admission, when the cervical admission, when the dilatation at admission is 9 to 10 cm, there's no need for pathograph. It's already almost in second stage. Those scheduled for elective cesarean section, those going for emergency cesarean section immediately on admission. Patient with gestational is less than 34 weeks. For term labor, you don't need a pathograph for it. All right? Any gestational less than 34 weeks, no need for pathograph. Women going, when they come, they are already coming for cesarean section, emergency, yes, no need. Those going for elective CS, no need. Women who on admission at the cervical dilation, 90 no need for pathograph. So note this, these are potential things that will come in your CBT. Next slide. The principle behind the use of the WHO pathograph. The latent phase of labor occurs up to 4 cm. The active phase starts at 4 and ends at 4 cervical dilatation. The latent phase should not last longer than 8 hours. In the active phase of labor, the cervical dilatation should be at least occurring at 1 centimeter per hour. A lag of 4 hours between slowing of labor and the need for intervention is unlikely to compromise the fetus or the mother, and therefore avoid unnecessary intervention. Next slide. A recommended VE interval of 4 hours. There are preset lines, the alert and action line, drawn parallel to each other, the 4 hours interval between them, and at a gradient of 1 centimeter per hour. It is good in detecting deviations from normal labor, but it does not replace careful assessment of the mother and the fetus. It can be used for all labors in hospitals, but at the primary healthcare level, it is indicated for only low-risk labors. High-risk labors need hospital care. Next slide. What are the components of the pathograph? The pathograph comprises of 3 components: the fetal record, the record of the progress of labor, and the maternal record. Next slide. The record of the progress of labor, this is the most important part of the pathograph and consists of the cervical dilatation plotted against time. That's the cervical graph. The main features of this graph are the latent phase, the active phase, the alert line, the actual line, which is 4 hours. The alert line starts from 0. But if you look at the WHO pathograph, it starts from 4 cm, right? Then the actual line starts, which is 4 hours to the right of the alert line. The time axis, the cervical dilatation, the level of the descent, and the frequency and duration of time contraction, as we discussed earlier. Next slide. The latent phase, the new WHO pathograph does not have a place for the latent phase. That's why it starts from 0, right? The latent phase of labor starts from onset of labor till cervical dilation of 4 cm. The normal duration of labor is 8 hours in the face of adequate uterine contractions. A labor going beyond this time should have full critical evaluation to plan the mode of delivery. It could be forced labor, it could be ongoing labor. Next slide. Now, the active phase of labor starts from 4 cm till full cervical dilatation, and the expected cervical dilatation rate should be 1 centimeter per hour. That represents the minimum of 1 centimeter per hour cervical dilatation and is drawn from 4 cm and ends at 10 cm. Next slide. If the cervical dilatation is lower than 1 centimeter per hour, then the graph moves to the right of the alert line. The parturient at the peripheral unit is now referred to a hospital where she will need a closer supervision. The axial line is drawn 4 hours to the right of the alert line. The cervical dilatation reaches across the axial line. A critical assessment of the cause of the delay must be done and appropriate intervention instituted. Next slide. The descent of the head in fifths. The feta is generally said to be engaged before labor, especially in primary gravida. But in African women, it is known that the head descent starts in the late first stage of labor, sometimes in the second stage. Yes, African women can start labor with the head still high up. In the case of breech presentation, the station notation with respect to the scalp spine is necessary. You don't use descent in breech presentation. Descent is only used in cephalic presentation. Next slide. So this is the descent. 5/5, the head is floating, has not entered the pelvis. 4/5 has started entering. 3/5, significant proportion has entered. 2/5, it is fully engaged. 1/5, and 5, when you 0/5, the head is wholly into the pelvis. Next slide. Now, this is how you assess the descent. How much of the head is palpable? In fifths, using your 5 fingers, is the whole of the head palpable according to the size of your 5 fingers? Next slide. The descent is a step most of you tend to miss when you're asked to examine a pregnant woman in OSCE. Always remember to do, because it is something that is expected. Now, the head descent in station notation. When you have, in terms of station is assessed during VE by palpating how much of the head is at the level of the ischial spine. Has the level reached the ischial spine, or has it not? If the ischial spine is considered to be level 0, if the head is 1 centimeter above the ischial spine, it's -1. If it's 2 centimeters above the ischial spine, it's -2. The higher the number of centimeters ahead the ischial spine, the higher the number of negative scores. But if the head is 1 centimeter below the ischial spine, it's +1. 2 centimeters below the ischial spine, +2. 3 cm below the ischial spine, +3. Plus is the more the head is going towards the vagina, the more the plus is. Next slide. Now, the quality of uterine contraction is plotted beneath the time axis. The frequency of the contraction is counted in 10 minutes. The duration of each contraction is calculated in seconds. Now, what you do, if the woman is having 3 contractions, each one will last maybe 10 minutes, 10 seconds, the other and 20 seconds, the other and 15 seconds. You add all of them and divide by 3. Next slide, to give you the average duration of contraction. This is how you plot. Now, we said, if you look at this, each of these columns, it has 5 boxes. So the number of boxes you shade depends on the number of contractions in 10 minutes. We said you should have 3 to 5 contractions in 10 minutes. So it means she's having 2 contractions, you're going to shade 2 boxes. having three boxes. 5 contractions, 10 minutes, 5 boxes. 4 contractions, 4 boxes. Now, what about the duration? If she's having contraction less than 20 seconds, that's a weak contraction, you put dots inside the box, inside the appropriate box, whether 1 or 2, depending on the number of contractions. If she's having contraction lasting between 20 to 40 seconds, so it's a moderate contraction, you draw hatchet lines, slanted lines in the box. The number of boxes depend on the number of contractions in 10 minutes. She's having contraction lasting 40 to 60 seconds. Then those are strong contractions, you shed the whole box. If it's 3 contractions lasting 40 to 60 seconds, you shed 2 boxes. If it's 3 contractions, shed the appropriate number of boxes. Next slide. Next. The fetal graph, it consists of the fetal heart rate, the state of the lico, and the molding of the head. The fetal heart rate on the patograph, there's a 2 preset lines representing the normal range. Usually, the heart rate is a range, it's not a fixed. Ideally, it should last between 120 to 160 beats per minute on the old patograph, right? In the new patograph, some put 180 to 100 to 180. Now, any heart rate outside this range is considered abnormal. For wherever you're working, basically now it's 110 to 160. It keeps changing what the standard. But basically, anything less than 100 is worrisome. Anything more than 160 is worrisome. So and then you look at the patograph, you're supposed to monitor beta at every 30 minutes, right? You plot it on the graph. Next slide. The state of the lico. When the membrane is intact, you indicate it on the patograph where the column for the row for the lico, you put I, which means intact. When the membrane has ruptured, and you look at the color of the lico and put an appropriate notation. When the membrane ruptured and there's no lico, you didn't see any lico, you put A, means absent. It means there's oligohydramnios probably. If the lico that came out is bloody, you put B. If the lico is clear, you put C. While if the lico is meconium stain, you put M. When a membrane ruptured during labor, you record the appropriate time as follows. If the membrane rupture was artificial, they put ARM, artificial rupture of membranes. The membrane rupture spontaneous, you put SRM or SROM. Next slide. Molding of the head. This is usually plotted as follows. Now, 0 when the skull bones are normally separated and you can feel the sutures easily. When you have +1, when the sutures are just touching each other. +2, when the bones are overlapping, but you can easily reduce them. You can easily separate them. +3 is when you have the bones are overlapping, but you cannot reduce, you cannot separate the bones. They have overlapped at the irreducible. Next slide. The maternal condition. Of course, the patograph, you have a space for monitoring the fetal, the maternal pulse rate, which is done every 30 minutes, temperature 4 hourly, blood pressure 4 hourly or more, depending on the indication. Urinalysis, urine is flow is measured every 2 to 4 hours. Then, of course, you examine the volume of urine produced in 2 hours. You do the analysis for protein and acetone. Record the drugs and IV fluids given to the woman during labor. And then, of course, drugs could be analgesics such as petidine in the early first stage of labor, or when there's vomiting, you give her Phenergan. You also space for oxytocin augmentation. Record the number of units of oxytocin per 500 mils or per liter that is used and the number of doses per minute. Indicate the number of doses per minute in the appropriate box. Next slide. Next slide, please. What is the pattern of progress? The pattern of labor progress is described as normal when the cervical dilatation reaches 4 centimeters or more within 4 hours of admission in the latent phase. When the cervical dilatation occurs at a rate of more than or equal to 1 centimeter per hour in the active phase. On the other hand, labor is described as abnormal when there's prolonged latent phase, when the latent phase lasts longer than 8 hours, is said to be abnormal. Next, when the active phase, next. Now you can also classify abnormal labor as primary dysfunctional labor when the cervical dilatation occurs at less than 1 centimeter per hour throughout the active phase of labor. Right from the beginning, cervix dilating at less than 1 centimeter per hour. And therefore, it deviates to the right side of the alert line. It may subsequently reach or cross the action line. This is primary dysfunction. Right from the beginning, it didn't start well. You can have secondary arrest of labor when there is normal progress of labor for some time with subsequent slowing or arrest of dilatation. The cervical dilatation then deviates to the right of the alert line and eventually reaches or crosses the action line. So the labor can be dysfunctional right from the beginning, which is primary, or secondary arrest when initially it was progressing 1 centimeter per hour, then it stops. Next slide. How do you manage labor? You make a rapid evaluation of the general condition of the mother, including the vital signs, pulse rate, blood pressure, respiration, temperature on admission. Next slide. Assess the fetal condition, which include counting the fetal heart rate, which is done immediately after uterine contraction. And it is counted for 1 whole minute every 30 minutes during the active phase of labor and every 5 minutes in the second stage of labor. If there are fetal abnormalities, such as a rate of less than 100 or more than 160, you suspect fetal distress. And usually, at that time, if you do ARM and you find meconium stent lico with abnormal fetal heart rate, it tells you the fetus is in distress and you should commence appropriate measures, which means you put the patient in left lateral position, you give her oxygen, you set IV normal saline. If you're augmenting, you stop the augmentation, and then commence the IV fluid for about 30 minutes. You monitor the heartbeat. If the fetal heart rate changes, returns to normal, then it means your augmentation is a problem. And therefore, you decide what to do. If it's in second stage, you can decide to do instrumental delivery, or you resort to emergency cesarean section. Next slide. The membranes have ruptured. You should note the color of liquor. Presence of thick meconium indicates the need for close monitoring and possible intervention for the management of fetal distress. Absence of fluid draining after ruptured membranes are indication of reduced liquor volume, which is associated with also fetal distress. So, next slide. Normal latent and active phases. Do not intervene with augmentation unless complication develops. No need to do artificial rupture of membranes in the latent phase of labor. And you can do ARM at any time in the active phase of labor. Between alert and action lines, patient should be managed, if the patient is in a health center, a smaller facility, she should be transferred to a hospital with essential obstetric function. And ARM should be done if membranes are intact and observed for a while. In the referral hospital, ARM should be done and routine observation instituted before definitive decision making is done about mode of delivery. Next slide. At or beyond the action line, if the woman comes to the referral center at or beyond the action line, you should have full assessment. You consider commencing IV fluids, passing the catheter to drain the bladder, and appropriate analgesia. The options then include deliver her by cesarean section if there's fetal distress or there's evidence of obstruction, or you augment labor with oxytocin if there's no contraindication, and of course provide supportive therapy if progress is now satisfactory after the first review. Next slide. Now, this photograph shows you how a slow labor is managed. The woman came in. She was admitted at 5 centimeters of cervical dilatation, 4 cm cervical dilatation. But after 2 hours, she was still at 4 cm, right? Then at 4 hours, she was at 5 cm. Okay, no. At 1, 2, 3. She was then at 6 cm, and then eventually she progressed. But you see, where they commenced augmentation with oxytocin at 4 hours, when they found out that she was still at the same dilatation. So we now commenced augmentation with 10 units of oxytocin in 1 liter, and it was dropping at 10 drops per minute initially. No, yes, at 15 drops per minute. Then even at that, it was not progressing well. They increased it to 30 drops per minute, then 40 drops per minute. And by the time it was at 40 drops per minute, she eventually progressed and delivered. Next slide. Now, if labor, okay, previous slide. The previous slide. Previous, not previous. Good. Now she had augmentation commence. Next. And then V was done after 3 hours, then 2 more hours, then after 2 hours. If you, anytime you intervene in labor, you're not going to wait for 4 hours before you assess. No, you assess based on your finding. If you think that this woman needs closer assessment, you immediately assess within an hour. If there's no progress, then you have to decide. And whenever you're augmenting a woman, you're supposed to assess uterine contraction every 30 minutes so that you know whether your oxytocin infusion rate is adequate or you need to change it. Next slide. Membranes, and once the membranes have been ruptured, then you should commence broad spectrum antibiotics such as cephalosporin and gentamicin if the membranes have ruptured for more than 12 hours, because you should anticipate the occurrence of peripheral sepsis. Next slide. What is prolonged latent phase? If a woman has prolonged, you see, well, when latent phase has lasted more than 8 hours, but less than 24 hours, you assess the woman and what are your options? No action, or you may have to deliver by cesarean section. If there's fetal distress or you suspect CPD, you may also consider the possibility of doing artificial rupture of membranes and induction with oxytocin. Or you monitor her as per normal labor if she's still in labor. Next slide. If no progress, in terms of effacement and dilatation of the cervix, you now diagnose forced labor. So if a woman has been coming of labor pain and later you assess there's no cervical effacement or dilatation after 24 hours, it is forced labor. You just advise her and then investigate her for UTI. Do urinalysis to combine if you have proteins, nitrites, or leukocyte, then suspect UTI and give her appropriate treatment. Next slide. Fetal distress in a health center, transfer to a hospital. If there's fetal distress within a health facility that can do cesarean section, immediate resuscitation. Stop oxytocin augmentation, put the woman on the left side, and then give her fluids for hydration, commence oxygen, and do vaginal examination to rule out cord prolapse and to assess cervical dilatation. If she's already in second stage or almost in second stage and the head is engaged, you do instrumental delivery to deliver the baby. Next slide. Next slide. Assess the patient at short intervals. If the fetus recovers after your resuscitation, you continue labor. If the recovery is not adequate, you immediately deliver the baby. If the cervix is not fully dilated and the head is high, you can do CS. But if the cervix is fully dilated or almost fully dilated and the head is low, you do assisted vaginal delivery. That's what I said earlier. Let's go. Next slide. So, summary for labor events at the second page of the pathograph. That's the first page of the pathograph is the pictorial depiction of the labor itself. The second page, when you turn it around, the summary of the events. Usually that part is filled after delivery. Next slide. Okay, so I think this is the last slide. So thank you. We can go and pray and come back for the last lecture. Today we are taking 3. If you have any question, just give your questions now. When we come back, we take the last lecture and then we conclude. Right, we'll come back in 30 minutes. Let's say 20 minutes, we should be back. Thank you. Hello, hello. Can we go? Can we continue? Hello, can we continue? Hello. Okay. So we are going to discuss cesarean section. Dr. Ben. Okay. We're going to discuss cesarean section now. So this is the outline. We'll look at the definition. What is cesarean section? It's an operation or a procedure carried out to deliver the fetus and the placenta and the fetal placental tissues through an incision in the anterior abdominal wall and uterine walls after the age of viability. So if a similar procedure is done before the age of viability, definitely it's not a cesarean section. But if it is done after the age of viability, it is a cesarean section. Next slide, please. So let's look at the historical data about cesarean section. Numerous references exist in ancient literature about cesarean section in Hindu, Egyptian, Chinese, Grecian, Roman, and other folklore. The early history of cesarean section remains shrouded in myth and mystery, and of course, it's of dubious accuracy because remember, history is written by the victor, and the world, civilizations have evolved through conquest, and therefore, the victor at every war of civilizations is the one who determines the history. So history itself is dubious. Next slide. There are tales in both Western and non-Western culture of this procedure. In Greek mythology, Apollo removed Asclepius, who's the father of medicine, from his mother's womb surgically. Even though this same Asclepius is of doubtful origin. In some historical context, it is the African or Egyptian physician, astronomer, scientist, Imhotep, that the Greeks name Asclepius as the father of medicine. Next slide. It is believed to be delivered, the name is believed to be delivered from the assumed surgical birth of Julius Caesar. Of course, this story is unlikely since his mother, Aurelia, is reputed to have lived to hear of her son's invasion of Britain. In the past, before the advent of anesthesia and antisepsis, every cesarean birth is associated with either one of two outcomes. Either the baby lives or both the birth mother and the baby are lost. And because at the time, Roman law prohibits burying a pregnant woman with her fetus in utero. So even if the woman dies, the pregnant woman dies, even if the fetus is dead, the baby has to be removed from the womb before she's buried. That was the Roman law at that time. Next slide. The first written record of cesarean section comes from the land in the year 1500, when Jacob Nufa was said to have performed cesarean section on his wife. After several days of labor and help from 13 midwives, the wife was unable to deliver. A desperate husband eventually gained permission from the local authorities to attend the cesarean section. And the woman lived and subsequently gave birth normally to 5 children. It is doubtful now. That is just another far-fetched story. What did he use to stitch the uterus? What did he use to close the abdominal wall? What antisepsis did he use? Because this is before Joseph Lister. Next slide. Now, modern history of cesarean section is noted. It's actually attributed to the following. Murakir in 1926 popularized the use of transverse anterior transverse uterine incision. In the 1940s, when penicillins were developed, the advent of antibiotics reduced the morbidity associated with cesarean section, and therefore women started surviving cesarean section due to various indications. So currently, cesarean deliveries are performed for a variety of fetal and maternal indications. The indications have expanded to consider even the woman's wishes and preferences. We're talking about cesarean section for maternal choice, right? Next slide. Now, what is the incidence of cesarean section? Or what's the ideal cesarean section rate? The WHO recommends a cesarean section rate of 10 to 15%. However, this is because it is said that a cesarean section rate of 10 to 15% is associated with an increased maternal and fetal outcome without putting enough stress on the health system. However, globally, the cesarean section rate has continuously increased throughout the world, and the rates from different parts of the world have been reported. It is about 21.1% in developed countries of the world, 14.3% from the less developed countries, and about 2% for the least developed countries of the world. Next slide. We have to also factor in the fact that the developed countries have a lower birth rate, lower pregnancy rate, compared to the less developed and the least developed, which means the denominator is always larger in the less developed and least developed countries, which means eventually, essentially, statistically speaking, the rate will be lower. So these are factors, statistics is also be manipulated for several reasons. In Nigeria, the rate of cesarean section varies from one center to the other across hospitals and from one region to the other. A reported rate of 10.3% in Enugu, 10.5% in Makurdi, 11.4% in Zaria, and 15.4% in Jos. Namini Kana Teaching Hospital in Kano a reported cesarean section rate of 17.3%. The reported rate is about 17.3%, but this is not even the latest. The latest rate is about 22 to 25%. Virtue of what? Hospital data are affected by issue of referral. A lot of the emergency cesarean sections are based on patients that are referred with complicated labor. Next slide. So what are the reasons for the rising or the increase in this incidence of cesarean section rate? Now let's look at demographic factors first. Now, the age at marriage has changed. The age at first childbirth has changed. The proportion of women who are economically empowered and therefore who delay giving the first childbirth has increased. And therefore, these factors will also influence the cesarean section rate. Let me explain why. An economically empowered woman who's a CEO, who did not get married until the age of 30, 35, and whose first pregnancy was at the age of 35, would be more concerned about having few children and having children who are okay, both physically, economically, and psychologically, which means the pressure to have a safe delivery on her own, and the pressure that she insist or she transmit on the physician or the obstetrician is high. Therefore, such a woman is likely going to choose cesarean section for any reason. And another reason, at that age, if a woman first pregnancy at 35 years, at that age, some women have already developed chronic medical conditions such as diabetes or hypertension. And therefore, coexisting comorbidities increase the likelihood of a cesarean delivery. So that's another factor. Of course, with late pregnancy, issue of increasing rate of infertility, there's high risk of multiple pregnancy from either ovulation induction or artificial reproductive technology. With multiple pregnancy, with delayed pregnancy, high premium pregnancy, cesarean section is likely the result. Of course, iatrogenic factors, the increased use of intrapartum electronic fetal monitoring, the cardiotachograph, it is increased associated with higher rate of false negatives. The fetal rate is this deceleration, and then when you go and deliver the baby, you say fetal distress, the baby will be shouting the moment the baby comes out of the mother's womb. There are medical concerns. These factors I mentioned earlier are of serious concern to the physician, to the doctor. The woman got pregnant by IVF. She's 35. Even me as a doctor, I'll convince her for CS. I don't want stress of labor. If anything happens to labor, 10 years later, she will tell you her child is moved because she didn't manage her labor well. So these are medical legal concerns. Of course, repeat cesarean delivery. If a woman has had a cesarean section, there's a high chance of her having another cesarean section, even if she had one primary CS. The reasons are many. One, she will not be allowed to go beyond her EDD. If she goes beyond her EDD, standard practice do not recommend induction of labor. So she will have a CS. If there's any other obstetric reason, she will have a CS. So, and of course, the labor itself should not allow to have any prolonged labor. And again, even during labor, no augmentation is routinely done for them. Again, other iatrogenic factors, there is a decreased rate of vaginal breech delivery. This was also partly iatrogenic. There was a publication that came around 2000, the Hannah and Hannah trial, which showed that cesarean delivery is associated with better fetal outcome for breech. And therefore, people started rushing to have cesarean section. And at present, people have increased access to information. This information is available on the net.
Your patient are even aware. So a patient who has breech presentation will tell you she wants cesarean section. She doesn't want to undergo the stress of vaginal delivery. There's also decreased perinatal mortality, maternal mortality, morbidity, and mortality from cesarean section itself. Improvement in anesthesia, blood transfusion, availability of potent antibiotics have all decreased the morbidity and mortality associated with vaginal cesarean section. And therefore, women are more comfortable, and even the physicians are more comfortable with offering cesarean section. Of course, we said non-reassuring heart rate. Yeah, whenever you use electronic fetal monitoring, either electively or emergency, it is associated with a high rate of detecting fetal heart rate abnormalities. And once such abnormalities are found, people will tend to jump to conclusion of fetal distress to rush for cesarean section. Next slide. So how do you decrease the cesarean section rate? Well, the issue of immunization, adequate nutrition, girls, these are all related to issue of cesarean section for obstructed labor or contracted pelvis. Those ones, they apply. If there's no childhood diseases like measles, polio, no less contracted pelvis, less risk of obstructed labor. There's adequate nutrition, adequate pubertal pelvic growth is achieved, and less risk of contracted pelvis, and therefore lower risk of obstructed labor. Girl child education eliminates early marriage, and therefore the girl will have attained full growth potential before she marries, and therefore less incidence of obstructed labor. So those first three are addressing potential obstructed labor from contracted pelvis that will lead to cesarean section for obstructed labor. However, you can decrease cesarean section by appropriate and quality antenatal care. Where one, women are identified, those at risk of problems such as obstructed labor are identified, those with breech identified, and they are counseled about assisted breech delivery or about external cephalic version. There are no contraindications. Those with a previous cesarean section are identified, they are counseled, they are planned for VBAC. Those who may have prolonged labor pregnancy are counseled, and then during antenatal care, they are offered all interventions to prevent the need for induction of labor. So all this will reduce cesarean section rate. Another factor that could reduce cesarean section rate include the use of pathograph. We discussed earlier, when you use a pathograph, you prevent or identify abnormal labor and therefore prevent prolonged labor. And then, of course, identify those who have CPD, identify those with inefficient uterine contraction. Those with inefficient uterine contractions appropriately use interventions such as oxytocin augmentation to improve contractions and deliver them. Those with CPD appropriately diagnose them and offer them cesarean section at the right based on the situation. All right. Then, of course, provision of vaginal breech delivery for those who have been carefully selected is an option. Nowadays, a lot of doctors, including obstetricians, have no skill in conducting assisted vaginal breech delivery. And that in itself increases the cesarean section rate. Now, again, increased use of interventions like external cephalic version to convert breech or transverse to cephalic presentation, the use of instrumental deliveries, vacuum and forceps to deliver the baby when appropriate to reduce the cost of cesarean section. Next slide. What are the types of cesarean section? Cesarean section can be classified based on the timing, based on the number. Based on the timing, it can also be classified based on the gestational age. Based on the timing, it can be elective. When it is planned, the woman is not in labor and it is planned beforehand. For emergency, when it is done, either because the woman is in labor or she is pregnant but has developed a sudden complication that is that is life-threatening for both the mother and or the baby, and therefore she will have emergency delivery. So based on time, it can be elective or emergency. Based on the number, it can be the first cesarean section, which is known as the primary cesarean section, or repeat cesarean section, which can be the second, the third, the fourth, depends. Repeat cesarean section means the woman has had a previous cesarean section before and she's not having the cesarean section. It can be based on the gestational age. It can be a term cesarean section or a preterm, depending on the gestational age. Next slide. Next slide, please. Next slide. Okay. Now, what are the maternal indications? There are several indications for cesarean section. These indications are not really maternal. These are fetal-placental, some of them here. Placenta previa is fetal-placenta. Abruption placenta, live fetus is fetal-placenta. But primary gravidae breach is maternal. Two or more previous cesarean section is indication. Previous uterine rupture. Previous uterine scar, or as either is how can I select them? Hysterotomy or metroplasty. A woman who has had a previous surgery on the uterus, for instance, she had uterine incision, issues were incised to remove a baby before the age of viability, or she had repair of a congenital anomaly of the uterus, which is called metroplasty. She's a candidate for cesarean section because in most instances, these incisions were done at the upper uterine segment. Therefore, it is just like having a classical uterine cesarean section scar. Therefore, she will have a cesarean section. Then, if a woman has had a previous BVF repair, she will have cesarean section. Obstructed labor is also an indication. If she has severe preeclampsia or eclampsia of the febrile cervix, an indication. And then, of course, if she has pelvic tumors coexisting with pregnancy, is an indication. CPD, they're all indication in all instances. Next slide. Fetal indication. Now, fetal distress in the first stage of labor. The woman is in labor, there's fetal distress, but she's in first stage, which means the cervix, the vagal dilatation has not reached 10 centimeters. That's an indication for cesarean section. Cord prolapse in the first stage. The woman is in labor, she's less than 10 cm of vagal dilatation, but the cord has prolapsed. Abnormal lie, which can be transverse lie, oblique lie, unstable lie, there are indications for cesarean section. Abnormal presentation, first presentation, breach in the primary gravida, bra presentation, they are all indications for cesarean section. Bad obstetric history is not really maternal, but it's just, it's an obstetric indication. A woman who has had 2 or more previous adverse perinatal outcome, several infant death, she had labor, prolonged labor, baby died. So those are indications for cesarean section. Multiple pregnancy. She has a twin pregnancy and the leading twin is breech. That's an indication for cesarean section. Of course, postmortem CS. The woman just died, but the baby is alive. Do cesarean section within the first 2 to 3 minutes. Congenital abnormality of the uterus or the fetus. When you have a fetal abnormality that is incompatible with vaginal delivery, such as hydrocephalus, or when you have huge tumors. When you have conjoined twins that she cannot deliver by herself, you have to deliver them by cesarean section. These are some of the indications. There are many indications. Of course, maternal choice is an indication. Next slide. What are the contraindications to cesarean section? For every indication, there are contraindications, right? So there are contraindications to cesarean section. When you have compromised maternal status, when you have severe cardiac and pulmonary disease, in which the operation itself or the anesthesia may jeopardize maternal survival. Remember, when you have severe maternal disease in which the surgery or the anesthesia would jeopardize her survival. Because it is her survival that is of whether the fetus is fine, it is a survival that is of paramount importance. She has severe cardiac disease, severe pulmonary disease, severe kidney disease, whatever disease she has, even if the fetus is fine, but the surgery itself, the CS, will jeopardize her survival, you have to postpone and abandon that CS. When there are detected karyotypic or severe anomaly of the fetus that's incompatible with life, CS is contraindicated. Right? When there's an IUFD, intrauterine fetal death, of course, CS is contraindicated. Similarly, when there's disseminated intravascular coagulopathy, if there's DIC, severe bleeding tendency like that, you have to avoid CS, because going for CS in such a situation will lead to fetal maternal demise. You would operate and then you will not be able to secure hemorrhage, a hemostasis. Then there's no point. Next slide. So how do you as a house officer, it is expected that you are the one to prepare patients for cesarean section. One, there has to be a clear indication. It's important that a clear indication is there because surgery is licensed assault. You are licensed to assault a patient in the interest of the patient. So it means you must have a clear reason for this operation. So there has to be clear indication for cesarean section. Then there must be counseling and consent taking. The patient must be counseled about the surgery, why the options, if there are any, the alternatives, there are any, and then therefore she must have accepted that she understood all the counseling and has given her consent, which is written. And of course, you must do preoperative investigations before the surgery so that if there are any derangements, you need to optimize the patient before the surgery. These investigations include full blood count to assess the baseline hemoglobin, white cell count to rule out any occult infection, and then of course the platelet count to rule out any tendency for coagulopathy. You must do the urea electrolytes and creatinine to assess the renal function as baseline. And of course, ideally you should screen for infective morbidity such as transmissible infections that could be acquired in surgery, such as retroviral disease and hepatitis B surface antigen. Well, sometimes you may do clotting profile, especially in a patient who has had a previous history of bleeding diathesis, but it's not routinely done. Okay? You would group and cross-match at least 2 units of blood. And of course, you may require to do an obstetric ultrasound to assess the fetal well-being before the surgery. Next slide. Now, the patient should be on nil powers for 8 to 12 hours pre-op. This is traditional. The current guidelines suggest that the woman should be at least, the woman is recommended to have pre-op fasting of at least 2 hours from clear fluid and 6 hours from light meal and 8 hours from regular meal. So her last regular meal should be at least 8 hours before surgery, but she can still have a light meal or light meal 6 hours before surgery and 2 hours from clear fluid, including water. Which means a woman going for surgery can take water up to 2 hours before surgery. But due to problems with timing, sometimes there are logistic challenges. So you rarely allow patients to take beyond 6 hours. The reason that you say somebody can take light meal, she goes to eat akpu 6 hours or 4 hours before surgery. Then when something happens and she ends up with general anesthesia, when spinal has failed and she has failed, then you are liable. That's the problem. And of course, you commence, since you have placed the patient on nil powers, it is expected that ideally you should set up an IV line and commence IV fluids. Of course, you pass your catheter pre-op or you can pass it in the theater. Then, of course, in the theater, you give preoperative prophylactic antibiotics. And of course, where indicated, you should prepare for heparinization or thromboprophylaxis, depending on your anesthesia and depending on the patient herself. Of course, skin preparation. This is usually advocated currently. It's not advised that you shave the perineum or the lower abdomen. It is better to use clipper intra-op. As soon as you go into the theater, you shave the part because you're going to, especially now that we're using transverse and lower penicillin incision that is low. So we're going to use a plaster. If you don't shave that place very well, it's nasty when you're removing the plaster. So it's better to use clipper to shave off the area at surgery. It's better, just with less infection, less distress for the patient. Next slide. In the theater, the patient is placed in supine position with the left lateral tilt, 15 degrees left lateral tilt. Why? It's because you want to avoid the supine hypotension syndrome. It occurs in pregnant women because the heavy gravid uterus is naturally tilted to the right. Why? Because of two reasons. One, the sigmoid colon is usually full of feces because most pregnant women, late pregnancy, tend to have constipation. So it also contributes to pushing the uterus to the right. Again, the pulsatile hypovascular muscular aorta also pulsates and pushes the uterus to the right. So the uterus is usually naturally shifted to the right. And because of that, it tends to compress on the inferior vena cava, and that can reduce venous return to the heart, reduce the cardiac output, and compromise the fetus before you come in. So you shift the patient 15 degrees tilt to the left side, and then they do pre-oxygenation, and then of course they give her anesthesia as appropriate. But of course, you must know that in the theater you must have a pediatrician available, and it is expected that you ascertain that the fetus is alive before you cut. But we said IUFD is a contraindication cesarean section. So especially for emergencies, you should have a means of verifying that the fetus is alive before you put your knife. Next slide. Now, the choice of anesthesia varies. Could be general anesthesia, spinal anesthesia, epidural anesthesia, local infiltration. The most popular method of anesthesia for cesarean section now are spinal and epidural. Now, epidural is used in the setting where a patient has come into labor, she has had epidural placed for analgesia, for labor analgesia, and she ended up requiring cesarean section. They'll just top up and then she will have her CS. Or they can, when she's taking the theater, they can de facto put epidural catheter so that after the CS, she will still have epidural. They will give her postoperative analgesia using epidural. Those are options. But the commonest method in our environment is spinal anesthesia. General anesthesia is used even nowadays for serious critical emergencies like abruption of live baby, cord prolapse of live baby in first stage, fetal distress, because at that point, you don't have the luxury of time to ask the woman to sit down, bend over, clean the back. Sometimes it can take you 30 minutes, 1 hour before they put the spinal needle, and you don't have that luxury. So they still cause general anesthesia. Now, local infiltration is done in certain circumstances. When you have a patient who is very sick, severe respiratory disease, you can't give her general anesthesia. You are afraid of giving a spinal, and you don't have the skill or the capacity for epidural. Reason is that if you give spinal for somebody who has a severe compromised cardiovascular and respiratory problem, is that a spinal tends to cause hypotension, which will drop the blood pressure, and that means there's supposed to be compensatory response by the heart. And that one is not possible for somebody who has a severe cardiopulmonary disease. And therefore, if you give epidural, spinal in such a patient, the patient may die. So the options include local infiltration. Just give us some sedation or clean the place, use a mixture of xylocaine and bupivacaine to infiltrate the skin and the subcutaneous tissue, cut, infiltrate the rectus sheath and cut, and up to you get to the parietal peritoneum, where you instill your xylocaine on the peritoneum before you incise.
Usually the parietal peritoneum is the one that is sensitive. But you also have to remember that the bowel is sensitive to stretch, and therefore she must give given some drugs to avoid retching and vomiting. So local infiltration is occasionally done in certain patients. Next slide. So what are the steps or the techniques in cesarean section? Of course, like all surgery, there will be a skin incision. When you make your skin incision, get access to the peritoneal cavity, you have to take precautions, protect the other vital organs, expose the uterus properly, identify where you're going to make your incision, and then you make your incision on the lower segment of the uterus. So the other component, after your uterine incision, you deliver the fetus, you deliver the placenta, you close the uterus, you close the peritoneum, and you close the abdominal wall. Next slide. The commonest skin incisions nowadays are the Finestyle, the Joel Cohen. The Finestyle and the Joel Cohen. They are all related. The difference between them is that Finestyle is located about 1 to 2 cm above the symphysis pubis, very low. And it's usually, it's a sharp incision. You cut the skin, cut the subcutaneous tissue, and cut the rectus sheath. While Joel Cohen is about 2 to 3 cm above the Finestyle, and it is usually involves just a small incision on the skin, and other divisions are done bluntly. Then the other incision, midline incision, is done, especially if there's a previous midline incision on the patient's abdomen. You can't do inverted T. You go, then you can also do malar, also a transverse incision that's located at the same level the anterior sphenoiliac spine. So it's higher than Finestyle. The problem with malar is that it's associated with more bleeding because inevitably you meet the branch of the inferior epigastric clearly in the rectus sheath. If you're not careful, you cut it and have a serious bleeding. Next slide. So if they ask you 2 incisions, skin incision and cesarean section, Finestyle, malar, then other 2 you can mention, Finestyle, Joel Cohen. Next one you can say midline and malar, right? Now, when you want to compare between Finestyle and midline incision, now the midline incision, the Finestyle incision, yeah, because it's transverse, it usually takes longer time to perform. They say it takes about 53 minutes. That is for the whole surgery. It increases the surgery time to a total about 53 minutes. Now, it is difficult to extend because it is low down. It's merely a pelvic incision. It only exposes the pelvis. It does not allow you to actually have good access to the upper abdomen. And therefore, because of that, the exposure is limited. But then the good thing about it is that because the place is along a vascular area, wound breakage is rare, and of course it is cosmetically more appealing for women, and of course incisional hernia are very rare because of that, and it is less painful. On the other hand, the midline incision is fast, and the operation time is about 45 minutes, all in all. And it is easy to extend. You want to check anything, you need to explore other organs, it is easy. There's less bleeding, however, because the midline is the least vascular part of the abdominal wall. And therefore, it gives you superior exposure, better visualization, but it is poor, it has poor cosmetic value, and there's increased risk of incisional hernia. Next slide. So when you make your incision, you choose your incision based on type you want. You extend the incision down to the fatty layer. Remember, superficial fascia, the subcutaneous tissue is divided into 2, the abdominal wall, the superficial fascia of Campa, which is the fatty layer,
and the deeper layer of scapa, which is the fibrous layer. All right. So you make once you made the incision lower than the subcutaneous tissue, you now make a small incision on the rectus sheet, and then extend the incision on the rectus sheet to the full length of the skin incision. Either use scalpel or use dissecting scissors. In the midline, it is easier to identify, and you just divide and you separate the rectus muscle. The incision is extended the entire length of the wound by inserting the finger inserting the index finger of each hand and drawing the hands apart when you want to separate the muscle, the rectus muscles. Next slide. Next slide, please. Okay. So this is a low transverse incision. Incision was given. Now this is separating the rectus sheet in the midline. This pale area is where the rectus muscles are separated. Next slide. Next. Whoa. Chineke. Hello. What happened to the slides? Okay. This is separation of the rectus muscle. Next slide. Next, please. Good. Now, after separating the rectus muscles, the next layer is the parietal peritoneum. You identify the parietal peritoneum and enter at the superior aspect. Now, if you are doing cesarean section for obstructed labor or in second stage, it's better when you're going to enter the peritoneal cavity, hold the parietal peritoneum in the upper part of the incision so that you want to avoid the bladder that might be distended because of the obstruction. And of course, you have to remember that below the parietal peritoneum is the intestine. So you pick your parietal peritoneum with forceps, and with one forceps, then pick about 2 centimeters next to it, adjacent to it, then palpate in between them. The first artery forceps that you pick, you release it, and then pick closer to the second artery forceps, because if you pick with the first one, you elevate, second one will pick and elevate, then you release the parietal peritoneum in the first forceps, then hold it close to the second forceps, and now palpate. If there's no tissue in between, you incise the peritoneum and then gain access to the peritoneal cavity. Next slide. The peritoneum is supposed to be divided from up down longitudinally. Your incision, you made transverse, but divide the peritoneum longitudinally. All right. This is how you open the peritoneum. Next slide. Now, the visceral peritoneum, remember, it is the serosa of the uterus. So you identify the lower uterine segment where the peritoneum is loose between the bladder and the uterus. That's when you pick and incise the peritoneum between the bladder and the uterus. Next slide. Of course, after dividing the peritoneum between the bladder and the uterus, before you do it, first you put a Doyen's retractor to deflect the bladder down. Your assistant will retract the bladder down. Then you divide the parietal peritoneum. All right. And then after dividing the parietal peritoneum to the extent of your proposed incision, you now reapply the Doyen's retractor so that the lower leaf of the inside peritoneum will separate from the upper leaf so that you can clearly see the uterine muscles you're going to incise. Next slide. Now, this is how you're separating the peritoneum between the bladder and the uterus, all right? Next slide. Now, you have already incised the inside peritoneum, you have deflected the bladder down. So now, how do you cut the uterine muscle itself? The uterine incision, you have the low anterior, a low transverse incision, which was the one proposed by Murakami. That was say 1924, 1926. Murakami popularizes incision, anterior lower segment, transverse incision. Then you can have the classical cesarean section. Now, the classical cesarean section is the one that you cut longitudinally. This is C, is classical cesarean section. C is classical cesarean section. Then you have your E is the delete, is the low vertical, is delete. You can have inverted T. This inverted T is your, where is it? Is your B. Inverted T, J-shaped, are done because of certain peculiarities. But the commonest incision is low transverse incision. Then you can do inverted T. Inverted T is you made a lower segment incision, and then because, okay, this is E is your inverted T. You don't have adequate exposure, you now make a longitudinal incision in the lower segment to improve exposure. D is your J shape. You look at it, there's a lower segment incision with an extended cut on one side. This usually both D and E are done when you have difficulty with exposure, especially if you have a transverse line, impacted transverse line, or some other difficulty with delivery. B is your delete, vertical lower segment. It's usually done in obstructed labor when the lower segment has been elongated, and sometimes it's also okay. Then your lower transverse is your A. Your classical is your C. Next slide. Nowadays, the only indication for classical incision is when you're doing postmortem CS, when you're having placenta previa, preterm, placenta previa, lower segment is not formed, and there's a placenta previa. When you're doing cesarean section that is done at a very early gestation, let's say at 28, 29 weeks, and there's no lower segment, so you can do classical cesarean section. And the transverse incision is done at about 1 to 2 centimeters below the junction of the upper and lower segment. The incision is not a straight incision, it's curved, a smiley incision, and it is done by gentle strokes with the scalpel. It is extended laterally in a curved incision with a curvature upwards or with fingers. Once the membranes are ruptured, the baby is delivered within 3 minutes. It's expected the moment you make your incision on the uterus, the baby should be out within 3 minutes. And therefore, you should make adequate incision so that there will be no difficulty with extraction, because that difficulty with extraction can cause fetal distress itself. Next slide. What are the advantages of lower segment cesarean section? The lower segment is less vascular, so therefore there's less bleeding, and there's less risk of future rupture of the uterine scar. There's because of the less bleeding, the decreased risk of paralytic ileus and peritonitis. And because it's in the lower segment, there's also a less risk of adhesions and post-operative intestinal obstruction. And of course, because it is along the lines of the muscle fibers, there's easy and rapid healing of the uterine wound. Next slide. Please, this is advantages, note them, please. For classical cesarean section, it's a midline longitudinal incision that's done in the upper body of the uterus. What are the indications? One indication is transverse line with the fetal back inferior, or you can do it as a preliminary to cesarean hysterectomy when you're treating carcinoma of the cervix. You can do it when there's previous classical, for a woman that has had a previous classical scar, you can do it. When you have a large cervical fibroid that is making it difficult for you to access the lower segment, Now you can do classical cesarean section. So you have, now they can ask you the following or list 3 indications for classical cesarean section. One is transverse lie with fetal back inferior, previous classical cesarean section scar, large cervical fibroid, placenta previa with a large vessel in the lower segment. Next slide. Now, again, preterm delivery, you can also do when you have preterm delivery with poorly formed uterine segment, when you have severe adhesions to lower uterine segment, reducing accessibility, and postmortem. I mentioned this one, postmortem cesarean section. So there are about 5 indications for classical cesarean section incision on the uterus. Next slide. Low vertical incision, which is known as delay. You can do it when the lower segment is not formed, or when you want to cut the contraction band out of obstructed labor to deliver the baby. Classical lower vertical is very good when you have obstructed labor and you have a contraction band. Next slide. So when you compare the lower segment incision and classical cesarean section incision, what are the advantages and disadvantages? Now, lower segment cesarean section incision, there's less muscle damage, there's less hemorrhage. Compared to vertical incision, there's more damage to the muscle and more hemorrhage. Now, in terms of suture, when you are going to repair the uterus, the lower segment incision is easier because there's more fibrous tissue and less muscle in the lower segment compared to the upper segment, which is where you make your incision in the classical cesarean section. In this place, there's less fibrous tissue and more muscle tissue, which is more difficult and more rigid to repair. In fact, you need to repair the upper segment in 3 layers, not in 2 layers as in lower segment incision. Next slide, please. Now, what about technical difficulty? The size of incision may not be adequate and may be extended because of there's usually some technical difficulty with the lower segment. Sometimes you do the lower segment incision, you may need to extend it to the side like J shape or even inverted T because of less access. And then in the process, you may also open a vessel, you may extend the broad ligament or even open the uterine arteries. Again, this is less likely with the classical cesarean section because there's more exposure. Now, in risk of bladder injury is more with the lower segment incision compared to the classical incision. But the post-operative recovery is faster in the lower segment incision because the muscle layer is not thick, the fibrous tissue to your incision, your repair is very easy. But upper segment or classical incision is usually associated with a delayed post-op recovery. And long term, there is less adhesion formation in lower segment incision compared to classical cesarean section incision where there's more adhesion formation. Next slide. Now, in subsequent pregnancy, what are the risks? In subsequent pregnancy, there's a risk of scar rupture, the lower segment. In any pregnancy that has any uterus that has a scar, there's an increased risk of rupture of the uterus compared to a uterus that has no scar. However, when you compare lower segment incision and a classical cesarean section incision, the risk of scar rupture is 0.5% for lower segment incision, but it is 2.2% for classical cesarean section. So the risk of rupture is very high. It's higher. In fact, it's more than 4 times higher when you compare upper segment or classical cesarean section scar compared to lower segment. Next slide. Next slide, please. Next slide. Okay, so how made your decision on the uterus is to deliver the fetus. Deliver the fetus by lifting the head and then applying, lifting the head and applying some pressure on the uterine incision. Of course, the assistant will give you fundal pressure, or you may need to use outlet forceps to deliver the baby. Then you apply upward pressure on the vagina as you deliver the baby out. Next slide. Next slide. Okay. Oh, this is the baby. Baby is out. Usually when you deliver the baby, you lift the baby up, put the head down, a bit down. Even if you're placing the baby on the mother's, it should be head down a bit so that the respiratory, the fluid in the lungs and the airways will come down. As you are suctioning, everything will be better. Next slide. It is the end. So for breech, when you make your incision, you identify, get one limb out. If it's an extended breech, you flex the knee, get one limb out, and then gradually put traction on that knee. It will gradually expose the buttocks for you so that you get the other knee, the other leg out. Once you get one leg out, the other leg will follow. But you have to be careful so that you don't fracture any of the bones of the fetal leg. Next slide. Now, after delivery of fetus, you now ask your anesthetist to give oxytocin so that uterus will contract and the placenta also you now do controlled traction so that you deliver the placenta. You do cord traction so that you deliver the placenta, and it's done like an active stage of labor. As soon as you apply cord traction to deliver the placenta, you quickly use green methods to hold the uterine angles to reduce bleeding, and then of course, as much as possible, it is better to deliver the placenta by cord traction rather than manually because of the risk of infection and hemorrhage when you deliver the placenta manually. So next slide. So when you're going to repair, well, how do you repair? No, I need the previous slide. You jump one slide. Okay, next slide. There's one slide that is missing. Okay, fine. When you're going to repair the uterus, you have to look at issues. You have to visualize so that you repair better. And if you're having good visibility, you'll be able to have decreased blood loss. Okay, this is the issue of, okay, I'm talking about delivery. Good. So now what are the advantage? Oh, this is about where to repair. Do you repair the uterus while it is still in the abdominal cavity, or you repair it outside? If you notice, if you've been going to the theater, some repair the uterus while it is still in the abdominal cavity, while others will bring the uterus out. Now, the advantages of repairing the uterus while within outside the abdominal cavity is that when you bring the uterus out, you'll be able to look at every the edges of your incision, and therefore you'll be able to repair much better. And of course, when you bring it out, you have stretched the ligaments of the uterus, including the uterine artery ligament, and therefore there will be decreased blood loss. And of course, there's no increase in morbidity because of less. But however, by bringing the uterus out, you have stretched the pelvic splanchnic nerves, and therefore there will be pain. And of course, when you are going to return the uterus, you are going to manipulate the bowels, and there'll be vagal stimulation, and the patient may even want to start feeling the urge, may be nauseated, she may even vomit. So those are the disadvantages of bringing the uterus out. On the other hand, repairing the uterus inside reduces the risk of adhesion, reduces the risk of this vagal-induced vomiting and the pain. So that's the advantage. But of course, it has poor visualization. So you have to have some experience before you start you doing the repair inside. Next slide. If you're starting, it's better to bring the uterus out. This is
This is a repair with the uterus out. You bring the uterus abdominal wall, close it, then return it back. Next slide. How do you close the uterus? You close the uterus in 2 layers with continuous sutures. You use delayed absorbable materials such as vacuum. All right. Second layer, the second layer of your closure should bury the first layer. And this type of suture is known as Lambert sutures. Lambert suture, Lambert, Lambert sutures. Ensure that the first lateral suture is placed beyond the angle. Here is the angle of incision. You place the first suture at least 1 centimeter beyond the angle so that if there's any artery, you hold it before you start suturing. And then you start suturing from away from you, which means if you're a right-handed surgeon, you're on the right side of the patient, you should start suturing from the left, then come to you, because it is easier to suture from away towards you. And then place the sutures at least 1 centimeter apart. Your suture, especially the first layer, 1 centimeter apart, so that you'll be able to arrest bleeding. Next slide. This is the second layer closing the first layer. This is second layer closure, is closing the first layer. Next slide, please. Now, how do you close the visceral peritoneum? Others close the peritoneum, others don't. Some people will close the visceral peritoneum while they are doing the second layer of uterine closure. They close the first layer of the muscle. When they are closing the second layer, they pick the visceral peritoneum and attach it together. What's the advantage of closing the visceral peritoneum? You are restoring the anatomy, and therefore you are also reducing the risk of infection and risk of adhesion formation. And that's an advantage, because when you don't leave any raw area, there will be no adhesion formation. Next slide. No, next. Next. Previous slide. Okay, closure of the parietal peritoneum. Others don't advocate the closure of the parietal peritoneum. But as one of my organs says, every layer of the human body that you restore during surgery, please restore it back to its original shape before you close the woman. So which means close the visceral peritoneum, close the parietal peritoneum, close the fatty layer, close the rectus sheath, close the fatty layer, and then close the skin. Next slide. The RCOG recombination, the Royal College of Obstetrics and Gynecology recommends neither the closure of the visceral peritoneum and the parietal peritoneum as CS, because doing it increases operation time and therefore also increase the need for post-operative analgesia. And so to them, you should not close the visceral peritoneum, the parietal peritoneum. We dey close them for you. Next slide. Now, you think closure of the subcutaneous space should not be used. You should not routinely close unless the woman is fat. Simple. For fat women, it is better to close. Unless the woman has more than 2 centimeters of subcutaneous fat, because it does not reduce the risk of wound infection. So if the woman is a thin woman, there's no need for you to close the subcutaneous fat. But if she's fat, more than 2 cm fat layer, you have to close it for you to even approximate the tissues well. Superficial wound drain should not be used at CS, because they do not decrease the incidence of wound infection or wound hematoma. But for fat people, sometimes you have to consider that. Next slide. So this is the CS wound after closure. Skin closure, you can close the skin by interrupted sutures, or you can use staples. But the problem with stapler is that if your closure is rapid, but it is associated with more pain, you can use a subcuticular suture. Usually, this is the commonest method of closing the skin at cesarean section nowadays, what the women call sealing. In the computer, and they call sealing. That's what you do. You close it subcuticular with absorbable suture. Next slide. So how do you monitor the woman post-op? Of course, there's initially before the patient leaves the theater, there's monitoring at the recovery area where one-on-one observation is done. Usually with a monitor, you look at the airway control, cardiorespiratory stability, and ability to communicate. That's the recovery area immediately after when she's brought out of the operating suite. Then from the recovery area, she'll be taken to the reception and then eventually to the ward. That recovery monitoring is essential for medical legal reasons. Before the patient leaves the theater, you must be sure that everything is stable, the vital assembly. Because if she leaves the theater and goes to the ward, if anything untoward happens, the people in the theater anesthesia will say that they have done their own very well. So that monitoring is very important. In the ward, the woman should be observed every 30 minutes, the respiratory rate, the heart rate, the blood pressure, the pain and sedation should be observed every 30 minutes for the first 2 hours, then hourly if she's still. So for instance, so it means if you are doing every 30 minutes, in the first 2 hours you're going to record these things 4 times. So that's why if you have a monitor, just put the monitor and set it. It will keep the record for you and then you review it. Then of course, if the vitals are stable in the first 2 hours, then you monitor every hourly for the next 4 hours. Then you go to, if it's okay, you go to routine monitoring. For patients on epidural opiates and patient control analgesia on opiates, you monitor hourly during CS and then 2 hours plus 2 hours after discontinuation. Because if they are on epidural, especially with opiates, you need to monitor how much they are doing. But of course, when you discontinue epidural, you should monitor up to 2 hours after discontinuation because you want to know whether the opioid has escaped, has gone into the circulation, and can cause serious respiratory problem. Next slide. Care of the woman and baby. You provide additional support to help the woman start breastfeeding as soon as possible. Offer analgesia or diamorphine or whatever appropriate antibiotics you have, and then offer non-steroidal anti-inflammatory analgesia to reduce the need for opiates. Women who are feeding well and have no complication can eat and drink when they feel hungry or thirsty. Yes, commence feeding as soon as possible after surgery. For me, in practice, what I do is immediately the woman recovers the ability to move her legs, she should start eating and drinking liberally. Next slide. After regional anesthesia, remove catheter when the woman is mobile. So at least 12 hours post-op after spinal, remove the catheter. Remove wound dressing after 48 hours and keep the wound clean and dry. Yes. For elective CS, especially primary CS, remove the wound dressing after 48 hours, and that's all. And of course, you debrief the woman, discuss the reason for the CS and what was done as surgery and the medications, then discharge her home. You offer earlier discharge to women who are recovering with no fever or no complications. So that's why in private practice on day 3, day 2, day 3, we discharge patient after a CS. That is easier. Women tend to enjoy it more, even though we realize some women want to stay longer in the hospital where they'll be at the Next slide. Follow-up recovery following CS. Of course, offer postnatal care and post-op, specific post-op care and management of the pregnancy complications, prescribe analgesia, monitor wound healing, and inform woman when she can reduce her normal activities when pain is not distracting or restricting. Next slide. I think we're almost done. What are the complications? This include endometritis, thromboembolism, urinary tract infections, urinary tract trauma, including fistula, if there's leakage of urine. Next slide. So complication of CS, they can be anesthesia related, such as aspiration pneumonitis, aspiration syndrome for general anesthesia, hypotension for spinal anesthesia, Post-dural puncture headache or spinal headache for spinal anesthesia. Next slide. Of course, hemorrhage, which is for all surgeries, but for CS is important, can be due to uterine vessel damage, uterine atony, placenta previa or placenta accreta, may be due to lacerations of the uterus or vertical laceration into the vagina or even broad ligament injury. Yes, injuries can occur during CS. That's why you have to be careful. Next slide. There can be complications in the inner tract, especially after prolonged obstructed labor. These injuries may encroach into the vesicular space, or they may be injuries that will be due to lower vertical uterine incision. So the injuries can be iatrogenic or de novo from the complication of the labor itself. So careful and caution is important during the surgery. Next slide. For the GI, you can have ileus, because especially after prolonged obstructed labor, there has been electoral derangement from the obstructed labor, and then the surgery and bowel handling. Because of that, there will be paralytic ileus. There may be even some bowel distension sometimes. So in this case, you monitor closely and commence oral intake, because this decreases the time for the return of bowel movement, decrease post-operative stay, and also decrease abdominal distension. Next slide. Respiratory tract can be atelectasis or pneumonia, especially after aspiration pneumonitis following general anesthesia. They may also be treatment related, can be deep. How do you treat this atelectasis? Your deep breathing exercises and postural drainage, especially for patients who are in a bad shape. Next slide. Of course, physiotherapy will help you achieve all this. Thromboembolism is a major cause of maternal morbidity and mortality, especially in developed countries. There's increased chance of thromboembolism in the case of emergency cesarean section, with advanced maternal age, with obesity, or with inherited thrombophilia disorders. Next slide. So any patient that has had a history of thromboembolism or a history of thromboembolism in any of our relations should be watched out for. How do you offer prophylaxis against thromboembolism? Use of mechanical calf compression, use of calf compression stocking, use of subcutaneous heparin, that's Clexane. Next slide. I think we're almost done. Next slide, please. Okay, thank you very much. Any question? This man that asked question is not here.
Good evening, sir.
Good evening.
So I have a question.
Okay.
About vesical vaginal fistula. Please, what is 3 swab test?
Now, 3 swab test is just usually a test done in the clinic or in the theater to assess, to carefully identify the location of the fistula or where the fistula is arising from. Now, in this case, what you do is that you ask a woman, she go and void. You now put 3 distinct swabs, one in the upper vagina, one in the middle vagina, one in the lower vagina, right? Then you now either you ask her to, whether, this is usually done for those women in whom they don't have classical fistula that is continuous draining. So what you do is that you now ask them, you now instill a dye into the bladder. You pass a catheter, instill a dye into the bladder, and then ask them to walk around. When they walk around, you now ask them to come back, and you're going to examine them. Now, if the middle swab is soaked and colored, it means it is what? It is a mid-vaginal, at least a vesicovaginal fistula. If the upper swab is wet but it's not stained with the dye, it means it is likely a ureteric fistula. What happens in ureteric fistula is that they have obstructed label, and that area of the bladder, the trigone, where the ureters enter, are the ones that affect, that's the part that's affected. And therefore, the tissue that is lost on the vaginal wall and is direct in communication between that ureteric opening and the vagina. And therefore, it will be stained, but it will not be stained with the dye because the urine is not coming from the bladder. You understand? Now, if the lower swab is the one that is stained, now it could either be stress incontinence or a juxtaurethral fistula. The essence of the true swab test is for you to determine the type of fistula that is there, especially when the picture is not very clear. It helps you differentiate between a ureteric fistula because the dye you pass is into the vagina, into the bladder. So if you pass the dye into the bladder, you don't expect that. You expect that at least if that upper dye, or that upper part, is not stained with the dye, it tells you that the problem is the leakage from the ureter, not directly from the bladder, right? So it helps you differentiate the type of fistula you have. Of course, it's just part of the evaluation methods, but it's not foolproof because even a patient with stress incontinence can have the third swab stained with the dye, right? So you understand? Do you have any question?
Yes.
All right. So it is used to differentiate the type of fistula you have.
Okay,
Any other
sir.
question? All right.
Yes, another question.
Okay.
Sir, if a patient presents at 5 or 6 centimeter,
Okay.
5 or 6 centimeter cervical dilation,
Okay.
how will
Have
you?
plot on the pathograph?
Yes, sir.
Now, whenever you are plotting on a pathograph, this WHO pathograph that has a alert line, action line, if you notice, the alert line starts at 4 cm, right?
Yes, sir.
So you are going to place your finding at 5 centimeter on the alert line. Why? The reason is that is movement along that line is the minimum rate of cervical dilatation that you expect, which means she came at 5 cm. If you're going to examine her in 4 hours, you expect her to go at 9 cm. Go?
Yes, sir.
So, which means by the time you are examining her, if she's already 10 cm, then this labor is okay, it's beautiful. Labor is progressing very well because 1 centimeter per hour is minimum, right? But if you examine her in 4 hours and she is 8 cm, it means she's progressing at less than 1 centimeter per hour. And it means your next plotting will be to the right of the alert line because it's showing you that this labor is slow. And for you, it's important in this exam because sometimes they bring the pathograph. If you make the mistake of plotting that 5 cm, not on the alert line, you'll be confused on the follow-up session what to do. You understand me? So whenever you're starting your plotting, it should be on the alert line as long as that pathograph has that alert and action line. It should be on alert line. If they say when she came, she's 4 cm, so it's starting at the beginning of that alert line. They tell you she came at 6 cm. You're starting at 6 cm on the alert line. You understand?
Yes, sir.
Okay. Any other question?
Yes, sir. There is another question.
Okay.
So, for example, if the mother is having a comorbid condition like maybe severe pulmonary disease, and then she's having cephalopelvic disproportion, can you still go ahead and do cesarean section?
Good. Now, if you think she has severe pulmonary disease, and now she's in labor, she has cephalopelvic disproportion. Now remember, she has an obstetric indication for CS, right?
Yes, sir.
So, how you're going to do the CS depends on your anesthetist. You have already established an obstetric indication for the CS. So, what will depend now will be what the anesthetist feels. If he thinks he will not be able to give her either general anesthesia or spinal anesthesia, and he cannot give epidural. So the question is, what would you do? Objectively, what you would do depends on the facility. If you're in a hospital with a very good ICU, you can still go ahead to discuss, because this is the patient that requires multidisciplinary decision making. You sit down with the anesthetist, with the cardiologist or the pulmonologist, and make a decision about the best way to handle the situation. As an obstetrician, you don't take decisions alone, especially in patients with comorbidities. You discuss with the relevant people and take a joint decision. Of course, this decision that will be taken also must involve the patient and her relations. Because whatever consent you are taking in that case, it is a high-risk consent. Now, let me give you another scenario. Assuming she has severe pulmonary disease, she's breathless, and the baby is still alive, but the baby is preterm. You know it's different from a term baby, right? Let's say the baby is at 32 weeks compared to a woman who is the baby is at 37 weeks. You know the chance of survival of the fetus varies. The one at 32 weeks has lesser chance of surviving compared to the one at 37 weeks. So even the decision about the CS must be individualized based on circumstances. But overall, when there's comorbidity, the decision is taken jointly by the multi-specialist managing the patient. You as an obstetrician, you are concerned about the outcome of the pregnancy and the mother. But then there are people who are also treating the other comorbidities. So you have to jointly discuss with them and the anesthesiologist for you to choose the right course of action. But of course, all this discussion must involve the family. Because sometimes you may end up going to theater and the patient will die. So if you don't prepare well, you don't have the participation of other people, the medical implication is huge. So all this preparation is important so that you cover your own end. Both you, the anesthetist, the physician will be sure that what is necessary has been done before the decision to do cesarean section was finally taken. But overall, for you as an obstetrician, the first rule is that for all medical comorbidities, the best route of delivery is vaginal, unless there are genuine obstetric indications. For all medical comorbidities, the best route of delivery is vaginal, unless there are specific contraindications of vaginal delivery or there are clear obstetric indications for cesarean section. How about I've answered your question?
Yes, sir. Thank you, sir.
Hello? All right, any other question, please? If there's none, we call it a day. We shoot tomorrow. Okay, Alima, go ahead.
Sir, for example, now if the baby is breech, how will you plot the descent? Is it the same as cephalic presentation?
No. I said in breech, you don't assess descent. You indirectly assess it by vaginal examination. You do vaginal examination, and if the breech is at station 0, it means, you know, the equivalent of station 0 on descent is what? Is 2/5, right?
Yes, sir.
So what you do is that you come on the pathograph and put W, not O. O is the head, but W is the buttocks. You understand?
Yes, sir.
You put W, that means that's the buttocks. It's not the head.
Okay, sir.
All right. So any other question? Please feel free to ask your question. So you're welcome. So in the absence of any other question, we'll see you tomorrow. All right. All the best. Good night.